Let's go ahead and get started. Welcome everyone to our series of Buncke Clinic virtual visiting professors. Today we have the distinct honor of welcoming not only a thought leader but also a very dear friend, Dr. Paul Cederna from the University of Michigan. Dr. Cederna needs no introduction, but I'll do my best and try to do it in a relatively short time. He's, as we know, the chief of the section of plastic surgery at the University of Michigan and a professor in the Department of Biomedical Engineering. And you'll see, I'm sure, during this talk why he does have that title as well. And he's also the Robert O'Neill Collegiate Professor of Plastic Surgery in the Department of Surgery. Dr. Cederna has accomplished quite a bit, and these are just a few of the things that he's done. He was chairman of the Research Council. He was president of the American Society for Peripheral Nerve, president of the Michigan Academy of Plastic Surgeons. He was a member of the board of directors of ABPS, and most recently the chairman of the board of plastic surgery. He's on the board of directors of SPS, past president of PSF. You get the idea. There basically are very few things Dr. Cederna has not done. And I thought I'd include this picture from his chairmanship year. I thought it's great because, as he put it, it combines his two loves, which is plastic surgery as well as skiing. And this was a gift to him by the board, so it's a really fantastic gift. I had the privilege of visiting Dr. Cederna and his colleagues at the University of Michigan last year during my travels. And it was truly an incredible visit with what you would expect from Midwestern hospitality. And this is us at dinner with Dr. Cederna, Dr. Kuzan, and the rest of our colleagues here. I spent a fair amount of time learning about what Dr. Cederna does, and it's incredibly elegant, and he even was able to explain it to someone like me who doesn't know much about science. So it was a really incredible time, and I think on a personal level, really enjoyed kind of seeing the university and all the kind of the things that I had to offer, including I had a great sub at Zingerman's Deli, which was really fantastic. I had a great time spending time with him on his beautiful home, which is on the lake. And some of you may not know this, but Dr. Cederna is an incredible athlete who does many things, all kinds of skiing, snow skiing, water skiing, and his garage actually looks like a kind of a Sports Authority store or a big sporting goods store. Just really an all-around, well-rounded guy. And as I mentioned last week when Dr. Neumeister was giving a talk, I had the pleasure of traveling to Germany and spending more time with Dr. Cederna and other friends at the German microsurgery meeting, and also continued to learn about what he does there. But fortunately, it wasn't all work. We also had some time to just kind of hang out and enjoy some delicious German beer and also some delicious German treats. So it was a really fun trip to kind of spend time with friends. As Dr. Neumeister also mentioned last week, we were all gifted with really nice lederhosen, and Dr. Cederna clearly won the best legs contest, at least among the tourists in Munich, and for this he was quite popular. So with that, Paul, I want to welcome you again. Thank you so much for being with us. We're really looking forward to your talk. And I'm going to give you control now. Give me 1 second to, here we go. Let's see, we have 70 people already. That's great. Let me find you in the list. I can give you control in just 1 second. There we go. Okay, so you should see a prompt now that you've been made the presenter. And on the bottom of the screen, there should be a screen button that you should be able to share your desktop. Perfect.
Got it.
And I'm going to ask everyone to please mute your microphones and turn your webcams off, and I'll do the same for Dr. Cederna's talk. Thanks, Paul.
Yep, thank you. So can you hear me okay?
Hopefully. Yes, we can.
Okay,
yes, we can.
Great. All right. Well, thanks, Bobak, for that kind introduction. And thanks all of you for getting on with me. I'm excited to talk a little bit about peripheral nerves, RPNIs, creativity and innovation in surgery. But before I start, let's see. We aren't advancing. Let me see what. There we go. We're advancing now. So We had a great time when we were in Germany together. Here, Babak is doing what he does all the time, giving a ton of talks and enlightening all of us on some crazy microsurgical skills and amazing accomplishments in solving some of the most challenging reconstructive problems. But he's also well known in this capacity as well, hanging out with friends, getting food, getting drinks, and sort of increasing the network of people that he interfaces with. And absolutely all of you who know Babak know what a great guy he is and how much fun he is. And here we are hanging out. We are all so proud of our lederhosen. This was the greatest meeting ever, and it's the second best gift I've ever gotten, next to my ski for the American Board of Plastic Surgery. But the funny thing is he showed this picture before, but if you look at him, he has these sort of workman-like lederhosen, and mine are all fancy. I'm not sure why I have the fancy ones and he has the workman ones, because I'm clearly the blue-collar guy and he is not. You know, I mean, I don't know. And then look, Mike Neumeister has a sweet coat too. So you put it all together, we actually make a pretty legitimate German plastic surgeon. But anyway, this is Babak also just at the party at Ricardo Gianta's house. Amazing. I mean, what a skilled guy. Absolutely incredible. And this is after about 35 drinks, and he still was able to do that. Just think what he could do if he was sober. So anyway, I'm going to start talking about prosthetic control for people who have lost a limb with amputation. And this was a TV show in the US when I was a kid back in 1973, The $6 Million Man, and he was a bionic man. The thing that was amazing about that show is he had these two bionic legs and this bionic arm, and he had this bionic eye. He could see a mile or something. And he was the $6 million man back in 1973. So we've dropped close to $30 million in research in my lab. So really with inflation, we're really talking more about the $6 billion man instead. And this is actually an upcoming movie with Mark Wahlberg in it. And I've had the fortune to be able to help them work on developing the storyline for this. So it's going to actually be pretty fun. But if we think of the issues about limb loss, it's a huge problem. So in the United States alone, we have about 1.7 million people living with limb loss, and that's about 200,000 new amputations each year. And if we look worldwide, you can actually see that almost 25 million people in Asia are living with limb loss, which is a huge amount. So this is a problem that affects so many people. And if we look back a couple hundred years at these prosthetic limbs, you can see actually they're made of metal, but he can actually hold a spoon in one of his hands, and it actually isn't that bad. And then if you look at what we used back in like the 1960s, 1970s, there are these devices that have cables and rubber bands controlling these hooks. And then even if you look at the device that most people use now, this body-powered prosthetic, it really doesn't look that much different than what we had 200 years ago. So why is that? Well, the reason is that even though we have these beautiful prosthetic knees and prosthetic arms, prosthetic hands that allow you to hold a potato chip, or even this, the DECA arm, we have this beautiful mechanical device, but we have no way to control it. We have no interface. And so it's like having a Ferrari in your garage and no keys to drive the Ferrari. So what have people tried to do to get keys to drive that Ferrari? Well, what people have tried to do is they've tried to actually go into the brain. And if you put a probe into the brain, if you place the probe into the part of the brain that controls the hand, you can record central signals, feed those signals to a prosthetic limb and control that limb. And these devices come in many different forms, and there are many opportunities to harvest these signals. This woman right here has a probe in her motor cortex for her hand, and she's controlling this robotic arm, bringing this water bottle to her mouth. And you can see actually, it's pretty remarkable that she has an ability to control that arm and deliver that water bottle to her mouth. The problem is if you're a surgeon and you lose your arm, getting an arm back that works like this just isn't good enough. It's not going to allow you to do what you want. Or if you play the piano like Babak, you will never be able to play the piano again with control like that. You need better control. And when we try to use these brain control approaches, the signals are really low fidelity. They're not stable, and they scar up. And as soon as they scar up, the signals disappear and they stop working. And so in the big picture, you actually don't have an interface that's going to work very long. So ultimately, brain control of prosthetics might be a worthwhile function for quadriplegics that don't have the function of an arm or legs, to just give them really basic rudimentary function. Or maybe a paraplegic to give them legs, but otherwise probably not so helpful. The peripheral nervous system is perfect for interfacing, because in the peripheral nervous system, actually all of the signals that control the arm are segregated in individual nerves. So we can actually connect up with each of those individual nerves. And when we do, if we can pull those efferent motor action potentials out, we could control a prosthetic device with them, and we could get great control. We could get individual finger control. So what have people tried to do? So a lot of really good engineers tried to interface with these peripheral nerves using cuffs like this over here, using sieves where axons grow through holes in discs. The problem with these cuffs are, if this right here is thumb flexion and this is index finger flexion, and you have a cuff around the whole nerve, you actually won't be able to tell the difference between thumb flexion and index finger flexion. So this is worthless. The other thing is that the cuffs actually create a compressive neuropathy and ultimately stop working with time. People have used these sieves and axons grow through here, but as soon as they start moving around, those axons get damaged and stop working. This probe, which is called the Utah slant array, gets put into the nerves, and this can pick up signals to the nerves. The problem is all these shanks that go into the nerve damage the nerve and it stops working. And actually, we all know when you have an amputation, if you don't do anything with the end of that nerve, you can get an end neuroma. And with that end neuroma, you can have pain, you can't wear a prosthesis, and it prevents people from having any good function. So we need a solution that would allow us to take a prosthetic hand like this one, the Johns Hopkins MPL, and allow you to control individual fingers using efferent motor control from the brain, and provide sensory feedback by placing sensors on the ends of those fingers, and you can produce afferent sensory feedback. To do that, we need better control. We need to innovate. We need to do something different than the engineers did forever. And I love this saying, innovation is seeing what everyone else has seen and thinking what no one else has thought. And the reason this is important is our solution to this problem was actually doing something that other people had seen a million times, but no one actually thought about doing it. So our original design, this is the whiteboard in the lab, and this is some, as you can tell, it's super busy, and there's a million different ideas of how we're going to interface with the peripheral nervous system. The details of this are not important, other than to say that we spent a lot of time thinking about it and messing around with ideas. And our first idea was actually this, which I absolutely love, but is way too complicated, and we were never really going to do it. But this was an acellular muscle scaffold. We'd take gold or palladium wires and put them into the scaffold like this. We'd take an electroconductive polymer and put it on here, and then we'd grow up myocytes and put them on here, and then we'd reinnervate the whole construct and we'd connect to the nerve. So interesting idea, lots of fun creating it, and we worked for a long time doing it. This is the acellularized tissue we created. This is PDOT, the electroconductive polymer we put on there, and we were able to do all of these things. However, one of the things we also always do is we do these killer experiments. And these killer experiments are critical in innovation. I actually don't want to start down a path of creating something new and spend a year or 2 or 3 going down that path before I figure out that it doesn't work. I need to design an experiment up front that tells me either it's a good idea or it isn't. So we either move forward with it or we abandon it. And that is the critical component. And so our plan in my lab, fail early, fail often. Failure is a part of innovation, perhaps the most important part of the whole thing. My early plan was never fail, but that's a ridiculous plan and that's not possible. And so we really need to move forward. And as we move forward, we saw that when we grew these muscle cells up in culture, we could get them to stick where we wanted. We could get them reinnervated. The signals weren't particularly big. We were doing a bunch of cell culture the FDA would never let us do. And we were trying to take PDOT and put it into the body, and it wasn't approved for implantation in humans. So although it was a good idea, we abandoned that relatively early and moved forward. So the solution we ultimately came up with was the regenerative peripheral nerve interface. And all this is we take a small piece of free skeletal muscle graft, we put it on the end of a nerve and secure it around the end of the nerve, and that's it. And then what happens when an efferent motor action potential comes down that nerve, it depolarizes that muscle, we pick up those signals, and we control the prosthesis. This was not a new concept. This was actually something that they had used many years ago to try to treat facial paralysis. And they would take these tiny little skeletal muscle grafts, they'd put them in the face, they'd reinnervate them, they would work, they just didn't generate enough force to reanimate the face. So they decided that that was a failure. But in fact, for our purposes, we actually didn't need it to move anything. What we needed it to do was to just be reinnervated by the nerve so that we could get the function out to control the prosthetic. And so when we do an RPNI, the way it works is we take this free skeletal muscle graft. That skeletal muscle graft is supported just like a skin graft is through imbibition, inosculation, and revascularization. The muscle fibers degenerate and regenerate from the resident satellite cells, and ultimately they reinnervate. And here's a nice image of the axons reinnervating these muscle fibers. And here's a satellite cell sitting right on the surface of the sarcolemma of the muscle. And so clinically, then what we would do is we would take all pieces of muscle, put it on the end of the nerve fascia.
Please mute your microphone.
And this could be thumb flexion, index finger flexion, wrist flexion, but we could then identify individual functions we need to control. So you start thinking about pinching your thumb and index finger together. An efferent motor action potential comes down that small, but it makes a muscle contract, and then we have a huge EMG signal telling us, pinch your thumb and index finger together, and we get that function out. So as we were doing these experiments, we had done, 500, 1,000 rat experiments. And we were identifying that none of these rats were getting any neuromas. So we decided what we would do is we would actually start doing this operation just to treat neuromas. So we wanted to do prosthetic control, but in the meantime, for neuroma management, neuroma pain and phantom pain control, doing it for that made sense. So we'd take a small skeletal muscle graft, we'd wrap it around the end of the muscle, we'd treat their neuroma pain and phantom pain, and we'd be in good shape. And if we looked at these RPNIs over time, if we looked at them 12 months later, you actually saw that they reinnervated beautifully. This is a neurofilament stain coming down all the way to the neuromuscular junction. This is the motor end plate stained with alpha-bungara toxin, and these are them merged, and you see this beautiful reinnervation of this RPNI. And if we did iDisco staining, which is a way that you can subtract out all the cellular elements and leave only the nerve fibers, you can see that we have beautiful axons coming down into our muscle and the nerve coming and reinnervating the whole structure. And if we look at this in 3D, you can actually see the axons growing into this muscle and spreading out across the whole surface of the muscle and reinnervating the whole thing. This provides us a great opportunity to amplify those tiny little nerve signals and make them big signals, so we could actually tell when your brain was saying, even just fire a single motor unit. So now we have these patients that we did a number of RPNIs on to control neuroma pain and phantom pain. The very first patient was a young man who had lost his hand in a fireworks accident. He had painful neuromas in his median, ulnar, and dorsal radiosensory nerves. So I did RPNIs on all of his nerves to treat his neuroma pain and his phantom pain. After that, though, now we have all of these RPNIs in place, we could actually see, could we record signals from the RPNIs as we thought we could for prosthetic control? So with ultrasound guidance, we would find the RPNIs inside their arm. We then could take a wire and pass a wire through the skin directly into the RPNI. And this would allow us then to record signals. So this is the very first experiment we did. This is our subject right here. These are the wires going into his arm here that were placed with ultrasound. This is some aluminum foil trying to shield the wires, very high tech, very high tech. And this is him just looking at a computer screen telling him what to do. And this is the very first time we did it. And when we had wires in his ulnar nerve at the midpoint of his forearm, and we asked him to abduct his fingers, just abduct his fingers, these are the huge signals we saw, 300 microvolt peak to peak. Typically, motor efferent action potentials are 5, 8, 10 microvolts. So you see we have huge amplification of these signals, which give us the opportunity. This is him, his nerves, telling us he's abducting his fingers. And here's the RPNI that you see on ultrasound. Here's the wire coming down into it, and those are the signals recorded. So I'm just going to show you this for a second. So right here, he's looking at this computer screen right here. This computer hand is telling him what to do, and this is his avatar hand. This is what he is actually doing with his nerves. You will see this will be red if he's right and green if he's wrong. And this is his very first time controlling a computer avatar hand after not having a hand for 5 years. You can see now middle finger flexion, index finger flexion, thumb extension, middle finger flexion, and you see how fast he is between these functions, extension. And this is him, this is not practicing, this is no training, this is nothing. This is just intuitively his brain controlling his hand, which is absolutely remarkable. And that's the beautiful thing about interfacing with the peripheral nervous system is you don't have to learn anything because your nerves are doing what they did originally, nothing new. We also see we have proportional control. So here you see he's just moving the tip of his index finger through space, and he's just putting the tip of his index finger into that circle. And this shows us, mostly with prosthetic hands, when you make a hand closure thing, it goes, and that's it. Here he has really delicate control over individual motor units, which gives him the ability to position it in space, which is a nice opportunity if you're going to have somebody become a surgeon again to have nice, delicate, fine digital dexterity. So then we had a patient who had an electrocution injury and lost his arm just distal to his elbow. Because he had no residual innervated muscles in his forearm, I did 9 regenerative peripheral nerve interfaces on him for prosthetic control. So I did 2 radial nerve RPNIs, 4 median nerve RPNIs, and 3 ulnar nerve RPNIs. This gives us the opportunity then to provide him with individual finger control. And if you look here, all I'm asking him to do is flex his small finger, and I'm doing a dynamic ultrasound of his ulnar nerve RPNI. This is the ulnar nerve RPNI right here. This is the wire going down the center of it. And you see there's an RPNI here, there's an RPNI here, there's an RPNI here. So there's a bunch of different ones. But you can see how much those RPNIs contract. And that explains why those signals are so big we're recording. But that also tells us that even above the elbow, it doesn't matter what level we interface at, we can actually pull those efferent motor action potentials out of the peripheral nerve for individual functions and control a device with them. And here there's 4 signals. So I'll show you this. This is his median nerve. 1, 2, 3, 4 RPNIs in his median nerve. And you see just the one functioning as we're asking him to flex his thumb. That's it, just number 1. If you watch it again, only one contracting as he's, and so the others are moving around a little bit, but those are easy to just filter out because we know he's flexing his thumb. So those are obviously containing the fascicles that used to go to his FPL. So then we wrote an FDA IDE that would allow us to implant electrodes into a human. And this is one of multiple binders that were created, sent to the FDA to allow us to implant. And the very first patient we implanted with bipolar electrodes was in May of 2018. This is our team in the operating room. This is the high-tech way we kept track of what we were doing. And these are all the electrodes we put in for FPL, FDP index, FDP small finger, and so on. So these are all the areas we put all the bipolar electrodes in. And this is what he looked like when we were done. Keep in mind, these wires are coming through the skin because the FDA required us to have them percutaneously as a first step. These wires we're using are wires that have actually been indwelling wires in people for diaphragmatic pacing, for breathing prosthetics, for people who are high quadriplegics, who are vent dependent, to allow them to breathe without a ventilator. And they have come through the skin in those patients for up to 17 years. So pretty solid. And if we look at all of these bipolar electrodes we have in, we see the same thing. Huge signals from our RPNIs, huge signals compared to the noise. And if we look at all of the signals overall, we look at this thing SNR, the signal to the noise ratio of 65. The SNR, when you record directly from a nerve, is a little over 1.5. For us, it's huge, which means it's very easy for us to tell when a brain signal, efferent motor action potential, is coming down, telling them to flex their small finger. So now here we see the same thing. This is the cue hand telling him what to do, and this is his hand, his computer avatar hand. And you can see, once again, index finger flexion, thumb extension, thumb flexion, wrist flexion, finger abduction, thumb extension, ring finger flexion, and finger adduction. Remember earlier I was talking about how we had all these amazing prosthetic devices that were like a Ferrari and we didn't have keys to drive the Ferrari? Right there, just with this technique, just providing intrinsic hand function like this, we have already outstretched what prosthetics can do. Prosthetics don't have the ability to abduct fingers or adduct fingers. So just by recording directly from the nerves, we've been able to do that. Here you see thumb control on week 1 and positioning it in space. He comes back the next week and we don't recalibrate, we don't do anything. He comes in, we plug him in, and he starts using the prosthetic. The reason this is important is with a lot of the ways that you see prosthetic control with people, you have surface electrodes on them, and they may spend an hour or 2 or more calibrating the system so they can use a hand. The reality is you can't get people to brush their teeth after every meal. You're not going to get them to spend 2 hours every morning calibrating their hand to use a prosthetic. And so in this case, they have no calibration necessary. And for this patient, well over a year, we never had to recalibrate the hand. They came in and they just used it. So here he is now controlling the DECA hand, and he's just imitating Phil's motion right here, moving his thumb through space. Here he's doing a box and blocks, and the interesting thing here is, if you watch how he moves this hand, he's moving this finger around, getting it into position. Like here he moves his thumb out of the way as he's scooping up a couple of blocks. He's going to grab a couple of blocks here. He's going to turn them over. And you see he's really controlling this hand like a normal hand. It's really remarkable. It's really remarkable. This prosthetic is one of the more advanced prosthetics out there. Now here you see when he turns this key, he's going to turn his index finger and his thumb in relation to each other. He's not just twisting a wrist in circles, but he's actually twisting his thumb and index finger in relation to each other. So it's actually working like a normal hand. So pretty remarkable actually that he has that level of control to control a zipper, turn a key, pick up blocks, do all these different things. And now you watch, he's looking at this computer screen up here, and he's controlling the hand here. What I want you to notice is the thumb and index finger, we have independent control over. This hand, all 3 of these fingers, the middle, ring, and small fingers, all move as a single unit. They don't move independently. So you'll see those 3 move together.
Cool.
But you see how quickly he moves between different functions. It's really remarkable. And this is not possible with any of the surface approaches or anything. He can just switch between modes because we're recording from 8 channels all at the same time, which gives control like you would get with the normal hand. So here he makes a fist to pick that up. And he comes down here and he pinches to pick this up. Another fist, so he's mode shifting here to be able to do these things. And then he comes down here and he's got a point. Oh, he's got a point. There we go. To push the button. So it's quick mode switching, which is more naturalistic. So our second patient was an unfortunate woman who was 35 years old who had a necrotizing fasciitis. She had lots of attempts at salvaging of her limb. And here you see, this is her normal hand and this is her affected hand. This is her at rest and this is her making a fist. She had horrible chronic pain, neuroma pain and phantom pain, and was requesting to have her hand amputated. So we had lots of discussions with her about ultimately doing it. We had lots of different teams of doctors involved, and we ultimately proceeded with a transradial amputation for her, and we did regenerative peripheral nerve interfaces on her median nerve, 2 ulnar nerve ones, and her dorsal radius sensory nerve. So here she is after her amputation with a relatively long residual limb. After that, she wanted to get electrodes implanted, so we came back. She had no neuroma pain and phantom pain after that, so we were really happy that that was all resolved and she was feeling better. And then we went in and implanted 8 bipolar electrodes in her arm. We did EPL, EDC, FPL, a median RPNI, 2 ulnar RPNIs, FDP to index, and FCR. So those are the 8. And so here, she's doing the same thing. So I want you to look at a couple different things. This is the computer screen and she is seeing this hand. This right here is what she's doing. She's actually trying to imitate these motions with her normal hand, but we're actually recording what her phantom hand is doing, and that's this hand back here. If you watch her normal hand work, it actually doesn't work as well as her phantom avatar hand does. But you watch, she has great function, finger abduction, thumb flexion, finger extension, small finger flexion, finger abduction. And she flips between them really well. And this is no training. Once again, this is her just using the device. And so it's really exciting to see that we have the potential to provide all these functions back without actually requiring a whole bunch of training time. Now here she is with wrist pronation, rest, pointing, key pinch. There it is. Wrist flexion. The other thing to keep in mind is most of the interfaces with the brain and peripheral nervous system develop scar around them and they stop working with time. These interfaces, the more she uses her RPNIs to control this hand, the stronger those muscles will get and the bigger those signals will get. So actually over time, the signals will get even better. Now here, you'll see she's telling us what she's going to flex. This is a magnified view. This is a different hand. This is an eye limb. We're using a different hand here because she has a small arm and the other hand that you saw before was too heavy for her and she couldn't control it. So she's using this one, but you see she has individual finger control. And she'll just go through each finger. She'll tell you what she's doing and she'll just control them. So there is currently not a strategy that allows individual finger control like this out there. This prosthetic has individual finger control, but you see that this one actually is a little bit slower. So it isn't ideal just because it's a little bit slower, but that's one of the problems with these prosthetic devices is we've never had a way to control them in the past. And now that we do, they're not quite up to the capabilities that we have now. So if we look at thumb control, this is a really big deal. We all know thumb function is 40% of the function of the hand. So you saw this before, this kind of thumb control, his thumb opposition, all the different things. We see his 3 degree of freedom, but you look at his control over this thumb. So he has total control over that index finger and that thumb and can put them together, which is going to give him great function. Now you see her using this eye limb, and you see how slow this hand moves. It just is a slow moving hand, but it's smaller so she can control it. So she used a grip there. This is a key pinch she's using. But now you look, although she can control pronation, supination, the hand doesn't have that functionality. So she has to actually mechanically turn it. So you can see now some of the limitations in the prosthetic hands. In the past, those prosthetic hands were too good. Now they're not good enough. Now what I want to do is I want to show you what this setup is this is a sensorized DECA hand back here. This is the hand, and it has sensors in different areas of the hand. And what we're doing is when Phil back here pushes on this part of the hand, we then feed signals back through her RPNIs, the corresponding RPNIs for that anatomic area of the hand, for her to get sensation. So she can't see what's going on, and she's just pointing out on this hand where she's feeling those sensations. So now he's pushing on the ulnar border of the hand. She feels it. Tip of the ring finger, ulnar nerve RPNI. Palm of the hand, median RPNI. She can feel it. The interesting thing is we have two ulnar nerve RPNIs there. Both of them carry sensory information, both of them carry motor information, and they're different. So we can actually identify different anatomic areas for the different ulnar RPNIs. So where are we now? So we have stable RPNIs for 48 months in humans. They amplify these electrical signals, which allow us to provide really amazing control signals to give individual finger control. The signals are real high fidelity. We can interface with as many nerve fascicles as we need to provide as many degrees of freedom as we want. It can be performed on people many, many years after amputation, and we have ultimately an opportunity for sensory feedback. The thing to keep in mind is there's always a way to do it better than how we're doing it now. So we always strive to be better tomorrow than we were today. And as Thomas Edison says, find it. And I really do believe that. And so when we're thinking about these neuromas, we were worried about prosthetic control, but along the way, we found out that they seem to be helping neuroma pain and phantom pain. And we all know that there's a million different ways that people treat neuromas. There's all these local things of numbing gels and pads and orthopedic shoes, and there's all sorts of medications, including narcotics and things, and there's injections and there's stimulators, and there's lots of different operations, and none of them work particularly well. And this strategy is a way that we can actually address physiologically the end of the nerve. Motor and sensory axons need and want to reinnervate end organs, period, muscles and skin. And you actually can't stop axonal regeneration, even if you want. You can ligate the nerve, you can cap it, you can burn it, you can bury it in muscle, you can bury it in bone, you can run it over with your car, you can do anything you want. You can't actually stop it from regenerating. And so any strategy where you're really going to get a permanent solution, you really need to figure out a way to get the axons to stop regenerating and stop forming a neuroma. And so if they want to reinnervate an end organ, and if it's hard to stop them from sprouting and elongating, you need to give them something to do. You need to give them a target, and that is what the RPNI does. So I've had a lot of discussions with Lee Dellin about this over the years, and Lee Dellin actually just wrote a paper about this, about his early description of just burying a nerve into muscle. The biggest difference when you bury a nerve into a normal muscle is there are no targets for reinnervation in the normal muscle. So you're basically still going to get a neuroma. It's just going to be covered by some muscle, so you may not get as much direct stimulation of the neuroma. However, those axons in that neuroma have a really low depolarization potential, which means that they're just going to randomly fire anyway and still get pain. When you bury a nerve into an RPNI, every single muscle fiber is denervated. So all of them are available for reinnervation. So the very first patient we did this on was a patient who had had 13 operations on his leg. He was a above knee amputation patient with peripheral vascular disease. He had phantom pain and neuroma pain for 3 years. He had been on every single drug that you can be on without success. He had had electrical stimulation with no effect. He had desensitization, work hardening, no effect. Meditation, he actually said there was some improvement with meditation, but that was really the only thing that made even a little difference. He even had a dorsal column stimulator put in. So I took him to the OR, and he had previously had 2 sciatic neuromas resected, and it grew back every time. And the last time it was a high ligation. And this is actually where the ligation was at the end of the nerve, and this is the neuroma beyond where the ligation was performed. So what I did is I dissected the sciatic nerve into 3 branches. I put little muscle grafts around each of them, 1, 2, 3, and that's it. 18 months post-op, no neuroma pain, wearing a prosthesis 8 hours a day, a little bit of phantom pain, and no narcotics. So the first group of patients we did this on to treat symptomatic neuromas, I decided, once again, this was going to be fail early, fail often. This was our critical test to ensure that this works. So we took every patient that failed all of the treatments, and those are the ones we did this on originally. If it helped them, then there's probably some chance it would be worthwhile. So we took all the patients who had previously failed previous treatments for neuromas, and we took them to the OR, and we did RPNIs on them. And we had follow-up of at least 24 months. So this was not a situation where we caught them early and they were pain-free and their neuromas came back, but this is at least 2-year follow-up. And if we look at them, this was our very first group, 16 patients overall, and they had on average a pain duration of over 6 years. And this is the distribution of what kind of amputations they were. We did 46 RPNIs on them, and we treated lots of nerves in the upper extremity and the lower extremity, some sensory, some motor, some mixed. And you see the muscles that were used for the RPNIs, lots of different muscles used for the RPNIs. The important thing is, if we looked at their neuroma pain score pre-op to post-op, we see the neuroma pain score on a PROMIS measure was close to 9 pre-op and about 2.5 post-op. So the neuroma pain got substantially better, and their phantom pain went from an 8 to about a 4. So it was cut in about half. So overall, huge change for neuroma pain and phantom pain on this group who had failed everything before. And if we looked at pain interference, how much the pain that they're experiencing interferes with their everyday life, you see a significant reduction in that as well. And would they do it again? 13 out of the 16 said they would do it again. And 1 actually said they wouldn't. So it didn't work on everyone for sure. So that was really promising. And because that was so promising, then we decided, well, really what we ought to do is if we can stop these people from getting phantom pain, get set up in the centralization of the pain they get sometimes, and we could do it at the time of amputation, we could probably even make a bigger difference for them. So we then proceeded with doing prophylactic RPNIs at the time of amputation. And so what we did is we had an experimental group that either got RPNIs at the time of amputation and a group that got no RPNIs at the time of amputation. And we looked at their post-operative outcomes assessment for neuroma pain and phantom pain. We included patients that had at least 1 year follow-up. And then we recorded all the information about all of them. And you can see here our groups of patients. You see the number of patients in each group, 45 in each group. You see the BMI is pretty well matched. The only thing that's real different is the peripheral vascular disease was higher in our control group. Those were the vascular surgeons doing amputations and not doing RPNIs at the time of amputations. But overall, the groups were well matched. If you looked at the types, or the types of surgeons doing it, we had orthopedic surgeons, vascular surgeons, general surgeons, and plastic surgeons doing them. So you see in our prophylactic RPNI group, 81% was done by us in plastic surgery, and about half of them in the control group were done by vascular. So if we look at the total number of operations, you can see and how many surgeons participated. So lots of different surgeons participating in it. So this is not just the effect of a single surgeon. And you look at overall the types of amputations done. The groups were matched pretty well. And overall, you look at the average operative time, you do see the RPNI group. It does take about an hour longer to do all the RPNIs in this group. So it does take a little bit longer for sure. But if there's some benefit and outcome, it's worth it. And we look at the nerves, we see lots of different nerves in the prophylactic group in the lower extremity and the upper extremity, including all the way up on the brachial plexus. And total RPNIs, 159. The control group had all the standard treatments that you see from everyone: traction, neurectomy, suture, ligature, buried in muscle. Lots of different things were done in this group. So let's get to the important part. The postoperative complication rate, we see the complication rate overall was lower in our prophylactic RPNI group in blue compared to our yellow group. But this is really related to this group. This is a vascular surgery group, so I wouldn't pay a lot of attention to this part because this was really the types of patients we're doing the operations on. But if we look at 1 year, in the control group, we had 14% of them develop symptomatic neuromas at a year, and we didn't have a single symptomatic neuroma that developed in our prophylactic RPNI group. So that's pretty solid. And if we look at phantom pain, 90% of them had phantom pain in the control group, and 50% of them had some degree of phantom pain in our RPNI group. So a huge change over our control group using RPNIs. So I think you need to have axons doing something in order for them to prevent developing neuromas. RPNIs are really promising. A majority of our patients have reported really improved pain scores, high levels of satisfaction. It's really easy to perform. You see general surgeons doing it, orthopedic surgeons, vascular surgeons, everyone. So it's scalable across the, across the medical continuum. And to date, I've done 200 patients now with prophylactic RPNIs and treatment RPNIs. So these patients seem to be doing really, really well overall. So we now have a big grant from CDMRP. Ted Kung and Steve Kemp are looking at the mechanisms of pain, the central mechanism and the peripheral mechanisms, to really understand the phantom pain component of this, to figure out, is there something else that we can do to get that phantom pain down to 0 in those groups. It's a prospective evaluation. We're recruiting patients and it's ongoing. So just one more thing I just want to talk about briefly. And, innovation is seeing what everyone else has seen, but thinking what no one else has thought. So I love this. So I was actually sitting in a meeting and they were talking about glucose control, blood glucose control. And they were talking about how if the kidney gets denervated, the kidney increases excretion of glucose. So serum glucose then would decrease and urine glucose would go up. So I'm listening to this talk, hearing this talk, and I'm going, well, if you can denervate a kidney and make it excrete glucose, I could actually stimulate a kidney. I could get the nerves to the kidney, and I could block neural transmission to the kidney by high frequency stimulation. And if I did that, then could I get the urine glucose to go up and the serum glucose to go down? And so could I use stimulation of the kidney to control diabetes? So I'm talking to this guy that gave this talk and he goes, no, you can't do that. And I'm like, why can't you do that? And he goes, you can't do that. No one's done that. And I go, well, it makes sense, doesn't it? If I can temporarily block transmission, maybe I get the kidney to dump glucose and then I just can control diabetes. So, this entire concept was then instead of worrying about insulin, let's just control blood glucose. So he designed this killer experiment. So we took these rats and we cannulated their jugular vein. We trached them. I put stimulators on the nerves that go to their kidneys. I cannulated their ureters. And then what I would do is I could sample their blood from their tail, and then I could give them huge infusions of glucose so I could make their blood glucose go up, and I could stimulate their kidney in all sorts of different ways and see if I could control their blood glucose. So this is the big money shot. So here on the Y is blood glucose concentration. In the red is what your blood glucose is. In the yellow is urine glucose. And this bar right here is when I do high frequency stimulation, 50 kilohertz. And you can see as I come along here, the urine glucose is low, blood glucose is high. I turn the stimulator on, and immediately the kidney starts dumping glucose, and the blood glucose comes down. Boom. I shut the stimulator off, urine glucose goes down, blood glucose goes back up. So pretty cool. And as I do it over and over, we get the same thing. Before stimulation, blood glucose high. During stimulation, blood glucose low. After stimulation, high. In almost all cases, not every case, but almost all cases. So the interesting thing about this is that this is a situation where I can actually take some of the technology that we've used for prosthetic control, and I've applied it in a new area that people haven't done before, and it actually looks pretty promising. We've done about 50 rats to date, and it is really consistent, and it happens over and over. And we see with kilohertz frequency stimulation of the renal nerves, we can reduce blood glucose. So you could very easily create a closed loop system where you're constantly sampling blood glucose, stimulating the kidney accordingly, and just getting it to dump out the kidney. The reality is we have a huge amount of research to do on this yet. I mean, we got to figure out, are we going to hurt the kidney by making it dump glucose? A lot of different things, but it's really exciting, the possibility of being able to make this happen. And I love the idea that as plastic surgeons, we are in general incredibly innovative, creative people. All you have to do is go to the ASRM meeting and see those talks and realize how creative people are, or listen to a talk from Babak or Mike Neumeister or Don Chul or any number of people, and what amazing things that they're doing through their creativity. That creativity can apply to the research environment as well. And I really believe it's our responsibility to do that, because we can see things in a novel way, and we can make a huge difference, even in areas that aren't necessarily traditionally what is considered plastic surgery. Jay-Z is one of my heroes. I love this guy. And, and he says, I believe everyone in the world is born with genius level talent. Apply yourself to whatever you're genius at, and you can do anything in the world. And I really do believe that that applies to us in plastic surgery. That applies to everything that we do every single day. And that gives us an opportunity to solve some of the most challenging problems that we couldn't solve in the past. So I want to just thank all the groups that have funded this research over the years. I want to thank my team that has done a huge amount of work over the years. I want to thank Babak and all his partners at the Buncke Clinic for inviting me to talk, and thank all of you for getting on with me. I appreciate it. And I will stop there and answer any questions that anyone has. Thanks.
Thank you so much, Paul. Always an incredible talk, and it's really inspiring. And having visited you in person, I think I got to learn about your work in RPNI even more detail, and some of the questions I think that are being asked in the comment section, I think were answered for me, at least during my visit. So we'll definitely get to that. First off, apologies for some of the chiming earlier. I figured out halfway through how to turn that off, so hopefully it wasn't that bad. But we had a number of questions about the specific technique for the muscle cuff, with regards to how large a piece of muscle you use, what kind of sutures, and so on. Would you mind going into a little bit of detail with that?
Absolutely. So, so the muscle itself is it's 3 to 4 centimeters long, 15 millimeters wide, 2 to 3 millimeters thick. So it's really thin. It's got to be really thin, because if it's too thick, it won't revascularize, and then you'll get some central necrosis. But by making it 4 centimeters long and nice and thin and 15 millimeters wide, you have tons of targets for reinnervation, and so tons of opportunities for axons to reinnervate muscle fibers and shut the whole thing down.
Great. And in a case where it's an elective operation, for example, where you don't have spare muscle to take, for example, from an amputated part, do you have a preferred muscle that you typically use?
Yeah, so the muscle, yeah, so in general, particularly on patients with amputation, I don't like to take muscle out of the residual limb, because they need that bulk in that residual limb for fitting in their socket. So what I typically do in that case is I go to the vastus lateralis. I can make a tiny little incision in the vastus lateralis, and I can get as many pieces of muscle out of there as I want. It's nice, healthy muscle. It works great. They don't even know it's gone. So that's my strategy. That's the part that I like the most.
And actually, I did, after I visited you, I did 2 cases, both of which I took from the lower extremity of vastus lateralis muscle, as you did. And in both cases, these were long-standing neuroma pain patients. And I got to tell you, it certainly works. They're both much better. One of them is almost, I think, 8 or 9 months out now, almost a year, with significant improvement. And so I think I encourage many people out there who have these difficult cases to go ahead and give this a shot. We had a question, and again, I've heard the details of this in person, but we had a question of whether or not this technology or this concept can also be applied for sensory applications. I know you've done a lot of work on this as well. Would you mind just kind of mentioning at a high level, kind of if that's possible?
Yeah, so we have a number of different strategies. So for sensory nerves, there's a lot of work that was done by Julia Terzis and Jamie Bain back in the day, using sensory babysitting of muscle. And we would see these sensory nerves grow into the muscles. There are some sensory end organs in muscles that they reinnervate, the Golgi tendon organs and the spindle cells. So the sensory axons do reinnervate things in muscle. And then the rest just grow into the muscle and just stop growing. So we have seen effective use of RPNIs for pure sensory nerves. However, we have also created dermal sensory interfaces, which is essentially just deepithelialized skin. We take the deepithelialized skin and we wrap the deepithelialized skin around the end of a pure sensory nerve. And by doing that, we then create a lot of targets for reinnervation within this skin. Dave Brown, one of my partners here, does a lot of pain operations. So he's working with a lot of sensory nerves, and he prefers DSIs, dermal sensory interfaces, instead. But we have seen a nice impact with both RPNIs and the dermal sensory interfaces, both.
Got it. There was a question about neuromas in general. Do you believe that the mechanism of injury has something to do with the formation of painful neuromas? Obviously, this is kind of a more of a hypothetical, theoretical question, but what do you think about that?
Yeah, so there's no question in my mind, the greater the damage, the more likely you are to get set up with some pain syndrome of some variety. And the thing that's challenging when you have pain in a residual limb, so I didn't do a lot of amputations 10 years ago. I do a lot now. I see a lot of these things. I've learned a lot about it. There's a lot of mechanisms of pain in a residual limb, but a lot of people get these complex regional pain syndromes. A lot of people get a lot of different things, and the more devastating the injury and the more mangling the injury, the more likely they are to have it all set up for pain long term, I think. And so in those groups in particular, being able to manage the end of the nerve might at least reduce that component of the pain more. Mm-hmm. The other thing that's interesting is the people who've had neuroma pain and phantom pain for a decade, they get this centralization of pain. And so I've had a couple patients, they can't wear their prosthesis. They're not sleeping at night. I do RPNIs on them. They come back to clinic. They walk in their prosthesis. I say, how you doing? And they go, I'm feeling the same. I just hurt the same way. And I go, well, you just walked in on your prosthesis. How long are you wearing it? And they go 6 to 8 hours a day. And I go, well, you weren't wearing it pre-op. And they go, I know, but my pain's the same. And then I go, how much you sleeping at night? And they go, I'm sleeping, 6, 7 hours a night. And I go, well, you told me you didn't sleep more than 15 minutes at a time pre-op. And they go, I know, but my pain is the same. And it is so frustrating. And so we have to understand that pain better so we can help those people too, because that is a challenging group. So we can make that neuroma pain better for sure. And we can make that all better locally, but the centralization piece is a tough one.
Right. Yeah, that's a great point. We have Professor Balakrishnan from India, and I believe you have a question. Professor, are you there?
Yeah, I'm here.
Hi, how are you?
Fine. Paul, it was nice. Very interesting. Very research-oriented talk. My problem is in 2 areas. I do a lot of brachial plexus surgery cases. You do mention something about brachial plexus. Do you have an answer for the after brachial plexus? A lot of people come to us with pain in the limb, where we could not repair the nerves because they're all got avulsed. So do you have anything now the RPNI can be used where there's no stumps to use also. How are you going to sort out this problem of the neurologic pain in the brachial plexus injuries?
Yeah, so you know, in the plexus, if there's any way to fix any nerves, you fix them. That's the best way to treat a neuroma by far. If there's any kind of repair of any variety you can do. But you know, if you have a glenohumeral amputation or something like that, and you have bare brachial plexus, for me in those patients now, I've been doing RPNIs on every single cord and every nerve that's there, and so I'll do a bunch of them, and it actually helps and it works, because they're no different than down at the level of the wrist. They're the same nerves, they're just more intermingled. The functions are more intermingled. But even if I'm not planning on controlling a prosthetic in a patient with, with that, we're still doing that to try to control the pain. So number one priority obviously is fix those nerves if there's anything to fix, or repair if there's anything to repair. And then after that, control the end of the nerve. And I like RPNIs. I think and we've had really good success with that, even really proximally.
I have one more. See, the cases like the macrodactyly, no, they are the lipomatous tissue involving the nerves, the distal nerves, and even go up to the median nerve. Most of the time, the very major macrodactyly, you have to exercise those nerves. And those situations, we can't put any peripheral nerve anastomosis also. For those nerves, can we have this RPNI used for sensory purposes, mainly for a sensation of the hand?
Yep. So in that case, once again, you don't need as much. Either muscle for a RPNI or deepithelialized skin for a dermal sensory interface. You don't need as much because you don't need as many targets because the nerves are small. And so in that case, you can make much smaller ones. We have a paper that's coming out soon that's looking at all the experience in the hand with RPNIs for treating hand. And a lot of these people who've had really refractory problems with neuroma pain and phantom pain after finger amps, partial hand amps, and things like that. And so even in this group, I think that could work as well. So like for a digital nerve, I might take a 10 millimeter long piece, 10 millimeters by 5 millimeters, and just wrap the digital nerve with that and just put it in the palm.
It's okay for the distal now. Sometimes what we do, we take up a distal curtain, do an end to side anastomosis. I'm talking some of the time, the neuroma comes from more proximal, the lower third of the forearm. We had sometimes divide the median nerve to totally remove the tumor. So if that median nerve is left in the forearm, can we use this RPNI to connect to that so that they'll have some sensation in the hand and also innervate the thenar musculature?
Yep. So the end to side approach, people have tried that for a long time, and I think there's been some mixed results with that. I think it's different for motor nerves and sensory nerves for sure, and it's entirely dependent upon how many endoneurial conduits are present that the axons can occupy once they traverse the end to side neuropathy. But certainly any time that you give an opportunity for the axons to do something rather than just grow and create this tangled mess, you're going to be better off. And we're working with a group that does a partial hand prosthesis, and we're doing a number of experiments now to reestablish both function in a partial hand prosthetic and sensory feedback from those fingers in a partial hand using this exact same strategy. So we like those extra nerves because we can actually leverage those through the RPNIs for both control and sensory feedback.
Thank you very much for very interesting talk. I enjoyed it very well. Thank you. Thank you very much.
Thank you.
Paul, we'll do one final question because a number of people asked it, and I know it's a favorite topic of yours. But there's a few questions of RPNI versus TMR. So, would you mind just kind of making a comment as far as what your thoughts are and the pros and cons?
Sure. So thanks for that question. And I am perfectly happy sharing my opinions with all of you about it because I have shared these exact same opinions with the world, with Greg Dumanian sitting right next to me. So I don't love the idea of TMR. And the reason I don't love the idea of TMR is you're taking a massive nerve and you're putting it into a tiny nerve and you're not actually accounting for all the axons. If you have a nerve here, a big nerve this big here, and you're plugging into a tiny little motor branch here, and this is 10,000 axons here, and this is 1,000 here, there's only 1,000 axons that can go downstream. That means there's 9,000 axons unaccounted for, which means that you will have a neuroma in continuity, period. There is not a single one of us on this call who would ever take a big nerve and put it to a small nerve and go, yep, that looks good, we're done. And so I'm not sure why TMR that works. It doesn't make sense to me. So a lot of the TMR people now are doing RPNIs around their TMR. You know, Ian Valerio is, there's a bunch of people doing this and doing various modifications of it. But then if you're doing TMR and RPNIs, why not just do RPNIs? It doesn't make sense to do TMR. And you can't actually find good branches all the time for TMR. And the last thing is I actually don't want to denervate any muscles in my residual limb doing TMR, because I'm going to want those residual innervated muscles for control sites for prosthetic control. So I don't want to denervate them. And even if I'm not doing prosthetic control, I don't want to denervate them and shrink them, so I have less volume within my socket and a worse fit for my prosthetic. So I think Greg's Dumanian's idea of TMR early on was a great idea. I think it's awesome. I think RPNI is a way better idea. And there's certain foundational concepts around TMR that I don't quite understand. It doesn't make sense. One additional comment about TMR is a lot of times people say, I know we maybe have a lot of unaccounted for axons, but motor axons don't give neuroma pain. They say, in that if it's just a pure motor nerve, they're not going to have pain. The reality is there's no such thing as a pure motor nerve. Every single motor nerve has sensory afferents, every one. So there's no such thing as a pure motor nerve. And there's actually no such thing as a pure sensory nerve. Even when we think of Searle's got 2% motor in it. And so, you know, so the reality is there's always sensory there. And so having a bunch of unaccounted for axons doesn't make sense. Denervating muscles in a residual limb doesn't make sense. And then doing TMR and RPNI together doesn't make sense to me.
Yeah. Well, you certainly make a very good argument, and I think it does make intuitive sense. Paul, I want to end by actually just reading you some comments, because I think it just reinforces, you know, how kind of well received your talk has been. Thanks for the great ideas and innovations, super innovative thinking. You are on course to transforming stuff of science fiction to reality. Fantastic and inspiring talks, truly a plastic surgeon innovator. And the comments just keep going. And I think I want to also state that I think, you know, what you're doing is incredibly innovative.